All right, everyone, welcome back to March CHT Prep, where we're going to go through 10 free practice questions. The way this works, if you haven't been here before, we're going to go through the questions. I'll read them out, and then once you get through all 10 questions, feel free to pause the video, take as much time as you need, go back through your answers, and then we will go back through, give the best possible choice for each answer, and then the rationale as well. So without further ado, let's get into it. Question 1. If a patient has greater PIP joint PROM with the MCP joint flexed than extended, what structure is tight? A. Extrinsic digital flexors. B. Intrinsic muscles. C. Triangular ligament. D. Oblique retinacular ligament. Question 2. Which of the following is indicated with a positive sulcus sign? A. Sternoclavicular joint instability. B. Multidirectional instability. C. SLAP lesion. D. Bankart lesion. Question 3. You are treating a patient with a mixed wound with a combination of black and red colors. What would be the most appropriate first goal of treatment? A. Maintain a moist wound environment. B. Absorption of excess drainage using dressings to absorb exudate. C. Protect the wound and soften eschar. D. Controlling bacteria with antibiotics such as Silvadene or Bactroban. Question 4. A patient presents to your clinic after a hand laceration which was closed by primary intention. Upon assessment, you notice the following: redness around the wound, hot skin temperature, and a foul odor. The patient complains of a sudden increase in pain the past few hours. Which of the following is true of their symptoms? A. The symptoms are cardinal signs of inflammation. B. The symptoms indicate infection. C. The symptoms indicate compartment syndrome. D. The symptoms indicate venous insufficiency. Question 5. Evaluation of a patient with shoulder pain reveals pain and weakness with resisted abduction and external rotation. They also have a positive external lag sign. Which of the following rotator cuff muscles is most likely affected? A. Teres minor. B. Infraspinatus. C. Supraspinatus. D. Subscapularis. Question 6. A positive result of which of the following is not a clinical sign of lateral epicondylosis? A. Pain with grip test with the elbow flexed. B. Pain with Cosen's test. C. Pain with Mills test. D. Pain with resisted wrist extension and radial deviation. Question 7. Which of the following is true when treating a type 1 non-displaced radial head fracture? A. The patient should use a sugar tongue orthosis for 2 to 3 weeks of immobilization. B. Early active motion should begin within 1 week of injury. C. AROM exercises should begin at 3 weeks after injury. D. Static progressive splinting should be initiated within 1 week of injury. Question 8. Your assessment reveals that a patient has weakness with resisted supination with the elbow extended, weakness of the finger and thumb extensor muscles, and reports no sensory disturbance. Resisted wrist extension and radial deviation is normal in comparison to the contralateral wrist. Which of the following treatment approaches would be most appropriate based on your assessment? A. Immobilization with the elbow at 90. Avoidance of activities requiring repetitive forearm pronation and nerve gliding exercises. B. Wrist immobilization orthosis, massage at the medial elbow, and a counterforce brace. C. Wrist immobilization orthosis, nerve gliding exercises, and ergonomic education. D. Immobilization with the elbow at 30 degrees extension during sleep, nerve gliding exercises, and ergonomic education. Question 9. Which of the following best describes a type 5 on the Freichmann classification system? A. Extra-articular fracture of the radius with the ulnar styloid. B. intra-articular fracture of the distal radial ulnar joint. C, intra-articular fracture of the radiocarpal joint. D, extra-articular fracture of the distal radial ulnar joint. Question 10. Which of the following is true regarding treatment of distal radius fractures? A, range of motion exercises to the wrist can begin 1 to 2 weeks postoperatively after open reduction internal fixation. B, joint mobilizations can be initiated in non-operative cases at 4 weeks. C, range of motion to the wrist can begin 1 to 2 weeks postoperatively after external fixation. D, scar management should be initiated 4 weeks postoperatively after ORIF. All right, everyone, congratulations. You made it through all 10 questions. Be sure to pause the video, take as much time as you need, commit to your answers, and now let's go back through the answers and I'll give you the best choice for each question that's available and the rationale. Okay, question 1, the best choice here is B, the intrinsic muscles. Flexor extrinsic tightness would be if you extend the wrists and fingers, they're going to have that composite flexor extrinsic tightness. Tightness of the ORL, you're going to test by extending the PIP and flexing the DIP joint. Question 2, the best answer here is B, multidirectional instability. The SLAP tests are going to be the O'Brien's active compression test and the Clunk test. The Bankart testing is going to be the apprehension or relocation testing. Question 3, the best possible answer here is C. So we always want to, with wounds, we always want to protect the healthy tissue, the red tissue. And treatment is going to be dependent on what we can do basically to get the other tissue colors to get to red. So here we know we already have some red, but we also have black, which is Eschar. So we want to protect the healthy tissue and then work to soften the Eschar so that we can turn that black wound into a red wound. Question 4, the best correct answer here is B, infection, which, is a pretty clear sign. Redness around the wound, especially if it's streaking, feverish skin, and definitely if there's an odor. Clear sign of infection, you should have them go to ER. Question 5, the best answer here is B, infraspinatus. To test for teres minor, you're going to do the drop sign at 45 degrees of external rotation or the Hornblower sign. Supraspinatus is tested with empty can or full can or the drop arm from 135 degrees of abduction. And then subscapularis tests are going to be the Gerber liftoff or the belly press type tests. Question 6, the best answer here is A. The grip test with the elbow extended is actually more clinically provocative for lateral epicondylosis. With it flexed, it is not. The other options are all common tests for lateral epicondylosis. Question 7, the best answer here is B. A non-displaced radial head fracture, especially type 1, they're typically treated without immobilization, and the best is usually early active motion. Just because elbows get stiff so quickly, you'd want to start the active range of motion exercises as soon as possible. For question 8, the best answer given here is C. The assessment provided in the description is indicative of radial nerve impingement syndrome, or like radial tunnel syndrome. So the best combination of answers are going to be wrist immobilization, radial nerve gliding, and then ergonomic education. The other answers all have something that is not generally helpful for this syndrome. For question 9, the best answer here is B. The letter A answer describes a type 2. The letter C describes a type 3. And then D is nothing. It can't be extra-articular and in the distal radial ulnar joint. With the Freichmann classification, if it helps, the odd numbers, I believe, are the same as the even number, except for with an ulnar styloid fracture as well. Question 10, the best answer here is A. In general, joint mobilization should not begin until after the fracture is healed. So for non-operative cases, likely about 8 weeks. Range of motion to the wrist won't begin after external fixation until the external fixator is removed, because the wrist can't really move with that in. And scar management should be initiated 2 days after the sutures are removed, which is generally around 2 to 3 weeks. All right, everyone, that is going to do it for March CHT practice questions. Feel free, leave any comments, questions below. If you have suggestions for other video types that you would like to see or things you think would be helpful as you prepare for the CHT exam, let me know. And thank you so much for watching. We'll see you in the next one.